All right. So anyway, today I thought I would just talk about really syphilis in pregnancy, but in general, STIs in pregnancy. Remember, syphilis is caused by the Treponema pallidum organism bacteria. It's kind of a cool organism. In Detroit, we actually were able to do dark field microscopy. We could actually see the suckers. So we would make the diagnosis on site when I worked for the STD clinic, because as an intern, we had to work at the social hygiene clinic, which I thought was hilarious. So it was called the social hygiene clinic. And we would basically see condyloma lata quite a bit on the secondary syphilis. And we could actually touch it to a slide, the weeping ulcers. And then you could take it to the dark field microscopist we had, and she could actually tell what even subspecies of treponema it was by the number of rotations and how it was spinning. It was the craziest thing ever. It was kind of disgusting when you see it, and then you realize why it's so infectious when you see how many bacteria are actually teeming out of the condyloma lata. The other thing I thought was interesting is syphilis has been recorded as far back as 500 years ago. So one thing you got to admire about syphilis, it certainly has been robust and persisted for quite a long time. So it's been around, documented in the history books for over 500 years, which I thought was also kind of interesting. And the reason, or the way they kind of discerned that, is in some of the history books, some of the lesions and some of the things they described in some of the royalty and stuff was clearly primary and secondary syphilis. And then they even think some of the rulers that went crazy and kind of lost their minds was probably due to neurosyphilis. Because you think about it, 500 years ago would have put you around the time of the Crusades, and I'm sure they were fairly lustful, and we were a couple hundred years before penicillin. So the thing why it's important for us in pregnancy is there's a 21% increased risk for stillbirth in untreated syphilis. There's a 6% increased risk for preterm delivery. There's a 9% increased risk for neonatal death. And the other thing that's interesting is there's a high association in STIs with syphilis, specifically HIV infection. So it seems like there's a high co-infection between HIV and syphilis, which I thought was interesting. Now, we were making good headway. And in females, there was a good nadir between 2000 and 2013. It had gone down to about 0.1 to 1.7 cases per 100,000 females. But then what they noticed in 2000, there started to be an uptick in the male infection rate. And that directly correlated in 2014 to 2018 to, now this is frightening, 172% increase in primary and secondary syphilis rates between those 4 years to 3 per 100,000. So we went from a low of 0.8 per 100,000 in the 2000s to now we're at about 3 per 100,000, which is frightening. There's also a 185% increase in congenital syphilis due to that increase in syphilis rates, which is scary because that's as high now as 33 cases per 100,000 births. And the other thing that you should take note of, as usual with the disparities in pregnancy, there seems to be a 5 times higher rate in the Black population over the white population. Okay, does that make sense? All right, so now this is kind of also bad news for us who are taking care of babies, because with congenital syphilis, the higher rates seem to be due to lack of access to prenatal care. And they think that the lack of access to prenatal care then leads to untreated mental and substance use disorders. There's a higher immigration to the US, and we know that syphilis is very prevalent in Central and South America. So a lot of the people coming up from Central and South America are bringing syphilis with them because they don't have good screening programs. It's also due to unstable housing. One thing we would note in Detroit, and we've seen it here in Muncie, syphilis will get into some of the homeless shelters. And as a result, the homeless shelters must obviously buddy up pretty intimately. And the thing you got to remember is you can get significant syphilis spread with oral genital spread. So people are under the misconception that you can't get syphilis from oral genital spread, but you can, just like herpes. And then there's poor compliance with screening guidelines. So we find that a lot of these patients are not adequately screened. And that leads to this question for you guys. Does anybody out there know the only STI that's required by the state of Indiana to be screened for in pregnancy? And I'm obviously, because I'm talking about syphilis, it's syphilis, but I thought because we run a hepatitis B on everybody, we run, you know, HIV is also recommended to do an opt-out program. So, you know, we do a lot of screening for the other STIs, but the only one that's absolutely required by the state of Indiana is syphilis screening. And you're required to have, or you're supposed to have by guidelines, 2 negative screening tests present prior to delivery. Now that can be done. So this is something else that we do incorrectly, is if you have someone with no increased risk factors and you do their screening syphilis at their first OB intake, and now we're doing a repeat HIV and RPR, or well, we'll show we're not using the RPR, but we're using the immunoassay at 28 weeks. Technically, you've satisfied the state requirements, so you're not really required to do that screening syphilis test at admission. However, because the risk has gone up, I still think it's a good idea to do that test at admission. But once again, you're satisfying the requirements if you do your initial and 28-week screen, especially on your stable couples, people with limited incomes, self-pays. You don't have to repeat it. And even though you'll get pushback from the nurses at admission, you really can opt not to do the testing at admission. The other thing that I thought was interesting is there's seems to be a reduction in public awareness of what a problem syphilis really is. And this I also thought was very interesting is some of the institutes that look at sexual transmitted diseases have actually blamed the sex education classes from going to a model of safe sex, basically in the junior highs and high schools of safe sex, to abstinence as the only way for safe control of STIs. As a result, in that change in philosophy of going from safe sexual practices to abstinence as the only safe practice, they've actually seen an increase in all the STIs, and specifically an increase in congenital syphilis, which I thought was interesting. The other thing that I thought was interesting, which I never really thought of, but this was a really good review article I'll send you guys from May of this year. It was actually from our clinical expert series in the Green Journal, was with the advent of all these new medications that prevent you from getting HIV, it seems like sexual behavior in the population is becoming more at risk again. So there's less use of condoms, there's less use of safe sexual practices, because now that people are on these, you know, HIV preventative medications, they seem to have a lot more at-risk behavior, which I thought was very interesting, and I never had any idea that that would impact the other STIs. I guess people figure you're not going to die from syphilis or herpes, and they're not as worried about it now that they don't fear getting HIV. Once again, all the other, this is kind of out of order, sorry. I added those slides in late. The background is, I mean, these are all the different kind of STIs you can kind of see during pregnancy. And even though we don't really treat bacterial vaginosis like the rest of them, it really is still considered an STI because the dad can be a carrier and keep reinfecting the mother. And that can be important on these resistant cases that you keep treating the mom and you have a difficult time on getting adequate treatment. Remember, sometimes treating the dad can actually help resolve it in the mother sometimes. And then the other ones we know about: trichomonas, gonorrhea, chlamydia, HIV, HPV, HSV, syphilis, Hep B, and Hep C. The goal of the World Health Organization and the CDC was to try to eradicate syphilis by 2005, because we saw this nadir in 2000 And, you know, there was this big push for eradication. But as the saying goes, it only takes one bad apple to infect a lot of people. As you can see in 2014, when the male rate increased, it exponentially increased the rest of the rates. So obviously it was a miserable failure, unlike smallpox or whatever, that we are anything but very far from eradication. The other thing is it's increasing in frequency, and not just nationwide. The state health department told me there has been an astronomical increase in syphilis cases in East Central Indiana, just so you're aware. Now, we've been pretty lucky in Muncie, apparently, but now I've positive syphilis cases. And the bad news is 2 of them are penicillin allergic, which really raises a dilemma for treatment. Remember, penicillin G, benzathine penicillin, or, you know, basically benzathine penicillin G is really the only treatment there is. So there is no alternative. So if someone is penicillin allergic, you have to admit them and do penicillin desensitization. Now, the good news is, instead of it being a 2-day desensitization like we've done in the past, there's actually a very slick order set in Cerner that actually describes how, I mean, it gives you all the orders. So all you have to do is activate the order set, and actually you get a pharmacy consult, and the pharmacist pretty much run it for you. And it has all the meds at the bedside, the EpiPens, the Benadryl. And it was kind of interesting because we did our first one on L&D, and I can tell you the labor and delivery nurses were absolutely having a conniption fit because they thought for sure this girl was going to have an anaphylactic shock reaction. But of course, as usual, she had no reaction at all. The other thing is there are some data, and I didn't know this, but Dr. Infectious disease pharmacist, his name, Luger, Dr. Luger, said there is now evidence, I heard this from Dr. Kafori as well, is that after 10 years of not being exposed to penicillin, a large percentage of people are actually becoming desensitized and actually can take penicillin again. So it is recommended, if you're not sure if somebody is penallergic, that you can do penicillin skin testing. But the problem during pregnancy is you don't want to really delay your testing very long. And I don't know about you, but trying to get somebody in emergently with Medicaid to a dermatologist to get skin testing is pretty good luck with that. I mean, the baby will be in 2nd grade before you can get them in, treat them and desensitize them to delay treatment. Remember, the one thing from medical school that we'd always have on our tests, and it's still probably on your boards, is the Jarisch-Herxheimer reaction, which is always the famous reaction, and it's from the killing of all the spirochetes, and so you overload your immune system with all these pyrogens because of the massive destruction of pyrochetes, which once again tells you how kind of grody really syphilis is, that it's such a high bacterial load that you actually have systemic symptoms of headache, myalgia, and fever. And you usually see that within the first 24 hours of treatment, especially with a heavy bacterial load in primary syphilis. The other thing to remember is we want to do partner treatment. And I have a slide that shows how to do expedited treatment under Indiana law. If you have a patient who's pregnant with an STI, that you can treat the partner without an examination, and with just a very quick verbal history, you can write for their medication, and you are exonerated by the state statute under Indiana law. And I have that actually to show you at the end. So you can treat the partner without an examination, and you're not falling outside the guidelines for licensure. Contact within 90 days, regardless of their serology testing. So the other thing that people make mistakes on is you have your co-band who has syphilis, you test their partner in the office at open door, let's say, and the partner tests negative, you still treat them even if it's been within 90 days of the exposure, because you don't know if they're still in that phase of not exposing symptoms. So regardless of the serology, the CDC recommends treatment of primary contacts within 90 days. And this is using the expedited partner treatment. I heard somebody come online. Did somebody have a question? No? Okay. The other thing is that the primary contact's greater than 90 days, but you don't have any testing available, you should go ahead and treat them too. So if a patient comes to your office, especially for you guys being FPs, and a guy says, well, my girlfriend finally told me, you know, she had syphilis 6 months ago, we would probably do testing at that point. But if you're in an outside clinic, or if you're at one of the FQHCs, you don't have testing readily available, my guess is you'll have penicillin, benzathine penicillin available, and you should just go ahead and treat them. And the other thing is areas with a high rate of syphilis, and that wasn't small caps us for US, that's us here in central Indiana. If you have a titer greater than 1 to 32 in late latent syphilis, you should be retreated again and treated as a positive. The problem is, remember, once you get a positive syphilis test, you're going to always have a positive syphilis test for a long time, for years sometimes. And that's why it's really important that we get the titer. And I'll discuss that a little bit later. Also, you want to notify their contacts within 3 months plus the duration of their primary syphilis, any contact within 6 months with symptoms of secondary syphilis, and within 1 year of early latent syphilis. So those are the people that the State Department of Health will knock on your door and, or will knock on the, not your door, but on the patient's contact's door. And, you know, that's certainly not one. So the 2 cases we've had so far, I've actually gotten a call from the health department, because the State Department of Health, this is such an important area, especially in pregnancy, that we have our own regional director for syphilis treatment within the East Central region. So, and you are, you need to test for HIV, whether they're pro-infection. And you also, this tertiary syphilis, but they have neurologic or secondary. Neurologic symptoms. Once you, so the way it happens, and I'll have a slide later on reflex DRL. Now, it doesn't matter which one, depending upon you get out, you'll get one or either one of these 2. The VDRL is just as good, and the reason you don't import to understand that these tests are very lab. Right? So if you have a patient who's here at Ball and they're getting their RPR, you should have them get it at Ball, not get it at OPTA, somebody different than we are. And you can get differences in titer up to 4-fold just because of a difference in methodology. And you want to have a decline in their titer by 4-fold within 12 months. Now, remember, that doesn't mean a 4-fold drop in their titer. That means a 4-fold, like a titer number. So what I mean by that is if you basically started out at 1 to 64, a 4-fold drop in titer will, because remember, with every titer, it's a doubling. And I've explained that to you before with like anti-D or any of your antibodies. Basically, the way the titers are done is a dilutional factor of 50%. So you basically, you know, 1 to 1, 1 to 2, 1 to 4, 1 to 8, 16, etc. So you would want to drop in titer of 2 titers, which will be a 4-fold drop, okay? Now, if you do not get a 4-fold drop in 12 months, you're considered an unsuccessful or failed treatment, and you have to retreat them as a weekly IM injection for 3 consecutive weeks. And that sucks. And the patient, 15 to 20% will actually fail treatment. So it's a pretty high failure. That's 1 in 8 to 1 in 5 if you think about it. So that's why it's critical. Now, people say, well, what if I can't find the patient and I can't do their follow-up titers? Trust me, the health department will find them and will track them down. And that is, you can actually be charged as a public health nuisance if you're evading the health department and you're moving around and you're trying not to be tracked. By law, you're supposed to report any changes process. Or a cold sore, a lesion on the labia. When you see a painless lesion that you don't think is herpes, you should be thinking of primary syphilis. And I can tell her, oh, I had a little pimple down there and I kept picking at it and then it became really infected and it got painful and now it looks all red and infected and it looks weeping and it looks like an infected abscess. It looks gnarly. And I can tell you, unless you've seen a lot of them like I have, you can be fooled sometimes thinking it's MRSA or you can think it's like folliculitis, but it's primary syphilis. The other thing is they typically have lymphadenopathy on that side. So if you see a right labial lesion, a lot of times they'll have right lymphadenopathy. They also have, the interesting thing is, and the reason why people get into latent syphilis is syphilis will run its course even without treatment. So usually that primary canker, chancre will go away within 6 weeks, even without treatment. Now, if they have HIV as a co-infection because of the immune suppression or not having good immunity, you can see multiple cankers unlike the usual single lesion. And you can already, and the other thing that's interesting, which I forgot, is you can actually see condyloma lata at the same time you're looking at a primary canker, which usually doesn't happen, but you can see it with HIV because there's such a delay in resolution. And without treatment, disseminated disease will occur, and that's the problem. So if they don't get treated by the time they start moving into secondary syphilis, well, now they have total dissemination, and that's what leads to the congenital syphilis because of the seeding of the actual placenta. And usually we see secondary disease 6 to 8 weeks after the syphilis occurs in women. It occurs 4 to 10 weeks after primary cankers. This is where you actually get the oral lesions, and this is when they become infectious just by oral spread. And it happens on the mucous membranes. They also have the typical maculopapillary rash that you typically hear about with syphilis. And the other thing is interesting is even during secondary syphilis, especially with HIV, you can have cankers reappear. It's highly contagious, so your condyloma lata can infect 50 to 60% transmission. I mean, that's huge. So essentially half the people that have condyloma lata can be infectious, and that's a very huge number. And it usually results in 1 to 6 months, regardless of treatment. However, if you do treat these people with condyloma lata, you usually get complete resolution within a couple of weeks. And it was kind of cool being at the STD clinic, I'm not going to lie, because you could see stuff that you just wouldn't even believe. And I actually did download if you ever gone to the CDC website, they have, this is really good for you guys, especially if you're doing community med. If you go to the CDC guidelines on sexually transmitted diseases, which I'll send you, it's 140 pages long, by the way. So that's why I didn't print it out, obviously. But I'll send it to you as a PDF file. The last update was in 2015. But if you go through it virtually, it has links to slide decks that you can use because it's governmental. And it shows you some of the gnarliest lesions you'll ever see. So if you want to really culture shock your high school kids or your middle school kids with some gnarly images, You just need to download those. It is pretty, wow. It was pretty impressive, actually. And they constantly update the slide deck, they said, for classic lesions, but I think they constantly update the slide deck for disgusting lesions to make it more and more disgusting. Basically, latent syphilis is what you're going to see a lot of times in pregnancy, because, I mean, a patient who has a painless lesion, most of those women will still come in and say, hey, I got the sore down here, I don't know what's going on. The second thing is condyloma lata. They're like, hey, it's weepy down here, I got this infection, what's going on? But where we get people, and this is two of our cases, was no lesions, no symptoms, and they're basically considered latent syphilis because now we have no idea when they got infected. Now, this is where you get your positive testing without objective findings. And it's broken down into basically two categories, early versus late. And late is now really known as unknown duration. So if you do not have an RPR, and this is what I found out from the health department, it was a really good talk I had with her because I was just getting a refresher course, and she was kind of impressed I knew as much as I did because I reminded her I worked at the social hygiene. If you have not had an RPR on your chart within the last 12 months, you are considered unknown duration. And the reason that's important is if you're early latent syphilis without lesions, a single shot is adequate treatment. But if you're in unknown duration or latent syphilis, I can't spell, sorry, latent syphilis, then you have to have 3 shots 1 week apart. And so my last patient, who was totally asymptomatic, had a positive test, gets called by the health department. She hasn't been pregnant in the last 3 years, hasn't been to the doctor. She's considered latent, and she had to get 3 injections in a row. The reason that's important is of course, this girl was, of course, question was, and I did for you and Dr. Luger, do I have to desensitize her after? Answer was, do you have to desensitize them before each weekly injection? Anybody out there have an idea? Super talkative group, thank you. He told me the reason why, so you get the 2nd and 3rd dose in your office. Actually, even though we treat them at 1 week intervals, that's because we want to keep the peak level adequate for 3 weeks, especially during pregnancy, that it's still in their system for 10 to 14 days. So they're still technically desensitized because they still have the penicillin floating around in their system for up to 2 weeks. So as long as you give it at the 7-day window, you are okay on not having to desensitize them. Now, I scared the bejesus out of my other patients who I'm treating for and tell them they can't be late, because you know how that goes. It's supposed to be done exactly at 7 days for 3 weeks to adequately treat it in pregnancy. I tell them if they miss a shot, if they're more than a day late for their shot, that they have to restart the whole sequence, and the State Department of Health will make them do that. So tell them it is critically important they're not late for their shot, or they'll have to restart their treatment of all 3 shots, and the health department will ensure that they get treated, so they're not going to be able to back out on it. So I tell them to do themselves a favor and just basically go forward with treatment and don't be, you know, a butt about it. The other thing about unknown duration, you get intermittent bacteremia, so you get seeding of the placenta, and there's a 10% risk for fetal infection, which is huge because you don't know how long they've had it, but that means 1 in 10 babies can still get congenital syphilis, even if they're totally asymptomatic. Syphilis because 10% of those babies will get congenital, be catastrophic. Basically, the reason they stay in latent syphilis is because their appropriate cell-mediated response continues them in latency, but under the stress of pregnancy, or sometimes if they get HIV co-infection, or if they basically have some other reason for immune suppression, it can flare up. This is also important if people are getting treated with all these new like Enbrel and things that are immunosuppressives for rheumatoid arthritis and a lot of these other collagen vascular disorders. They cannot remember they had a history of syphilis when they were younger, never got follow-up treatment because they weren't as militant as we are now. And that's once again the reason for the increasing rate. Basically, they get their Enbrel injection and then they get full-blown syphilis outbreak. What do you think the first thing that the mom's going to do is blame dad for being, for infidelity? But the reality is it was probably the immunosuppressive therapy that led to the re-outbreak. Tertiary syphilis is 40% of the untreated patients. This is where you get your benign gumas and your cardiovascular syphilis. Now, this is important because neurosyphilis is no longer considered tertiary syphilis. Neurosyphilis is basically an entity on its own. And it's also a much higher rate of co-infection with HIV. So if you see, and that's partly because they've had a long exposure, obviously, to at-risk behaviors. So if you have somebody with tertiary syphilis, you should really be retesting them for HIV. Neurosyphilis can happen anytime during the course of syphilis, early versus late. So early, they have the meningitis, uveitis dorsalis. I thought you see a patient 25 years old with a foot drop and you're like, oh shit. I mean, they could have neurosyphilis. They could have a palsy, they could have a stroke, but more commonly when you see somebody under 35 with these significant stroke, or not predominantly, but I mean, if you see somebody you can't figure out brain, but they're still having stroke-like symptoms, make sure you grab a syphilis on them. And I don't even care if they're 80 years old. I've had old men in the clinic who decided they were going to have a soiree at the nursing home, and it can basically wreak havoc in a nursing home where the entire freaking floor gets infected. I kid you not. I wouldn't have believed it if I wouldn't have heard it and seen it on my own. But yeah, grandma or grandpa will not necessarily not be sexually active, okay? The other thing, well, anyway, I'll leave that alone. Congenital syphilis basically can occur in 50 to 80% with untreated primary, secondary, or latent syphilis. And 10% happens in latent syphilis. Wow, you can tell how late it was getting last night as the slides wind down. That I saved down here on the bottom that I can send you if you're interested is, this is the SCT treatment guidelines. It doesn't show, yeah, so it's 140 pages long. It is quite a beast. It was last updated in 2015 and there's really nothing new to it. It is, let's see, fit visible. Oh, wow, that was the wrong way. Let's go to page level. So anyway, section on syphilis. And they even talk about management of persons who have a history of penicillin allergy. And they actually, on page 49, if you jump ahead to 49, there is a table there. If you go to an install, but they actually do have right here, if I zoom that up, you can see it's a table for oral desensitization and what the protocol is. And that's at, I believe, hourly intervals. So, 30 minutes. So 30 minutes before, and then doesn't mean you don't give out 1.5 million units of penicillin. Does that mean, and because you want that depot of has to come in 30 minutes and bam. And like I said, the weekly for 3, because she was perfectly fine for pucker. A little bit. So that's that one. So go to the CDC every is a committee opinion guideline because treating even without an examination, and they have for more rapid resolution. Of course, people were a little expedited treatment, kind of relatively benign. So that was cool. Where I got May of 20, so it's really up to date, and you can actually get once as long. Now I thought I had some really good tables in it, and since I could just jump to the articles, broken down early and late by timing of diagnosis, syphilis, which is, you see that? So this is the top, this is just, but acute and how pedunculate condyloma acuminata, it looks more flower or flower, which condyloma won't miss it. This is, and they were code necrotizing funis. Copy it out. Our screening algorithm, and Dr. Schreiner's ultrasound of a baby. Up here, CDC webpage, but it's not very copy and paste, easy to get into there, but it's very easy to follow. So this is the table of recommendations for pregnancy, STD during pregnancy, chlamydia at the first prenatal visit, gonorrhea, first prenatal visit, syphilis, first prenatal visit and early third trimester. BV doesn't support, or the evidence doesn't support screening. Same way with trick, same way with herpes. HIV, first and third. Hepatitis, first and third. HPV, no. Hepatitis C, first, and if increased risk factors. So that's those guidelines. And then, no, that's not right. I was trying to find Mel's. I think it's here in my PDF files. Yeah, reverse algorithm. This is the one that Dr. Schreiner sent me. This is excellent. She has this. So this talks about what they talk about reverse syphilis test algorithm. And what by that they mean is you're going to do an antibody test. So when you guys order your syphilis test, remember you don't order an RPR or you don't order an VDRL, even though you can get it. But what happens when you order an RPR now? Have you guys ever paid attention? You get the reverse syphilis test whether you order an RPR or not, because the lab is smarter than us. So it's actually measuring IgG and IgM antibodies to treponema. So you're actually getting a positive screen that is actually saying this patient had syphilis, probably. So if you get a positive screen, then you need to do, it will automatically get you an RPR in our lab within 24 hours. So if you have a negative screen, that's 96% of the patients in this study, there was basically, it's non-reactive. So that's why it's so good. The other reason why it's so good is it's automated, it's cheaper to run, and it's much more accurate. So you get a lot less false positives. So with the RPR, the problem was an ANA, pregnancy, There's all kinds of things that can give you a positive RPR that is not syphilis. And then you would have to do the treponema, FTA-ABS, fluorotreponema antibody absorption test for confirmation. Well, this is a little different screening, but you do the same kind of algorithm. If it's negative, you're negative. If it's positive, then or equivocal, you get an RPR. If the RPR is positive, then it's consistent with syphilis, past or current. If the RPR is non-reactive, though, you go to the next test, which is the TPPA test, and that would suggest if it's reactive exposure to syphilis. And then it says if previously treated, no further treatment unless re-exposure. If it is non-reactive or inconclusive, then you're supposed to retest them in 1 month. And I think that's very important. I didn't know that. So if the TPPA test is negative, you can reassure your patient, but you have to retest them in 1 month, or you're supposed to. And then once the patient's positive to be RPR positive, should be positive, they should only get RPR titers. There's no reason to redo the rapid test because they're going to always be positive. And then so you do the RPR, and that's how you monitor the RPR. That's what you're supposed to monitor. I'm sorry. And then the biggest thing on latent syphilis is the reverse algorithm is untreated latent syphilis. So that sounds like a mouthful, but it makes sense, right? So you get the thing that they like about the reverse algorithm is you will pick up women a lot more readily that have latent syphilis with no symptoms, much better than the RPR or VDRL, and it's much more rapid, which is also important because you want to treat them as soon as possible. And then basically, here's the test breakdown in a table form. So there you have it. That's all I got. We got 5 minutes for questions. You know, and I don't know if you guys have ever seen somebody get 1.2 million units. Don't be a jerk and give them 2.4 million in one hip, or the patient will not be able to walk out of your clinic. You'll have to wheelchair them out. Unfortunately, a lot of it comes in one vial. So the nurses take the needle off and draw off half of it. You just got to eyeball it. It's not exact. But when you see this stuff looks like freaking hand lotion, it is so thick that you'd be a believer that why we got to break it up, because the nurses were afraid, and you got to use like a 20 gauge needle. Otherwise you can't get it through the needle. It's so thick. So this stuff is nasty. I mean, it is like, it almost looks like Elmer's glue. It's so thick. So anyway, thanks for listening. I appreciate your time. Hopefully this helps. Jen, I will try to get all these put together in a single folder, and then I'll just send you the whole folder that you can pass on to the residents with all these handouts and stuff and the slides. I think that would be the easiest thing to do. Do you guys agree? I can look and see if I can see comments or whatever. Yep. So does that make sense to you guys? All right. Seeing no questions. Let me get rid of this. Let me move this over. I'll stop sharing now. Get back to this. Yeah, so do you guys have any questions? I thought it was pretty timely since we've had 2 or 3 cases here just recently. So there you go. Okay.